So I'm going to give it to a clinician here, okay? Mary Frances, okay? We heard higher age, prior thrombotic event associated with a higher risk. But as I remember, the ELN criteria now includes a platelet count of 1.5 million as high risk. Okay, so your patient is completely asymptomatic or has a young woman with headaches, migraine headaches, okay? Do you have to give that patient cytoreductive therapy? Can you give them aspirin? Are there any specific things you have to worry about
with a platelet count over 1.5 million? I would put them on interferon.
Okay.
And because they're also at a great risk of bleeding. And I mean, following those patients up and seeing them, once the platelet counts go over that level, they clinically run into problems.
So that is the level, 1.5
yes.
million.
So the PT1 story was interesting because when it started, the cutoff was 1,000, but then the data came out from the Italians and it was moved up to 1.5 million. And that group, which are really a low-risk group because they were between 40 and 60, with no previous thrombotic events, not on pharmacological therapy for diabetes or hypertension.
But just to clarify, the risk really with extreme thrombocytosis is really bleeding. It's not really thrombosis.
Yes,
and just to comment on the scenario you painted, I worry about women or men for that matter that have headaches, because to me that's a microvascular disturbance, and that's different. So those patients I actually do think need to be cytoreduced. I still struggle with what the goal platelet count is, but I do put them on cytoreductive therapy. So to me, there's two scenarios you're trying to address.
Yes, the question was one to bait you. You know, no, you do not give them aspirin. There's this pseudo-von Willebrand's situation that you can run into. So thank you for taking the bait there. And okay, but wait, before we finish this up, you guys are getting into some pretty fancy stuff. CALR type 1 mutation, there's type 2. I'm going to throw it to John. John, what's the difference between those, and is the effect the same in MF as it is in ET?
So I think the real answer is we probably don't really know. Mechanistically and biologically, I don't understand why there's a difference since they end up with the same frame-shift mutation, but there's a concept that there's a differential in terms of progression to myelofibrosis in ET between type 1 and type 2, and survival. So type 1 is a 52 base pair deletion, type 2 is a 5 base pair insertion. In primary myelofibrosis, if you have a type 1, that's considered a favorable risk mutation. However, in ET, that may be the opposite. But in my humble opinion, I'm not quite sure that that's crystal clear. So I don't necessarily treat patients differently based on their type of mutation.
And Moshe, does the JAK2 mutation mean anything to you in treating ET?
No. I treat ET, well, I'm a little bit more aggressive than what was discussed here, so I wouldn't get into it.
No, please, that's the purpose.
Because I have a large collection of young patients with ET, and they can have platelet count between 700,000 to 1 million, and I do treat them, typically with interferon. With the objectives that was described here, a long-term therapeutic objective, not just controlling the counts. So maybe that's a different aspect of this management. Now, I want to interject one point of...
Okay, before you leave that, okay, don't forget your point. But if you achieve a JAK2 negative mutant allele burden,
yes,
will you stop interferon like you would in CML?
I have done it in the past. I have seen patients that have a remission of 2 or 3 years without recurrence, and then I have seen a recurrence. So the experience is anecdotal. I don't have 200 patients that I can comment on. I can comment on single numbers, so in reality I cannot comment. And if people have more experience, it will be interesting to hear. It does happen. What is this? It is true remissions. The question is, do we get a situation of treatment discontinuation without the disease coming back? And that clearly has not been tested.
Given the cost and the symptoms with the drug,
but it hasn't been tested. It's an untested question.
So what did I cut you off?
One comment that I want to say on our next-gen sequencings that we have done. ET is the disease with the best outcome for a very simple reason. They have the lowest number of mutations, on the average only 1. Prefibrotic myelofibrosis is about 1.5. PV has more than 2. Myelofibrosis is on the average 5. So you see this transition of number of mutation as it relates fairly nicely to the outlook and survival.
Okay, well, I want to thank OncLive because, again, I've had a lot of fun this afternoon with the 4 of you and learned a lot. This has been a fantastic discussion. Before we conclude, I'd like to get final thoughts from each of our panelists. We'll start with you, Dr. McMullen.
So we live in exciting times. Myelofibrosis remains a major problem, but I'm old enough to have been around when we had nothing to offer them, and now we're looking at all these different drugs. I'm also excited about what's happening in polycythemia vera. Again, we have ruxolitinib, but there are more things coming into this realm as well, and we're looking at upfront trials in the future of new treatments in polycythemia vera.
Dr. Sherber?
Well, one of my big thoughts in seeing patients very frequently is it's just the idea that I don't know if we do enough in terms of prevention. We have so many drugs that are really doing amazing things and so much more in our arsenal. But I'd like to see us move more and more into potentially lower risk therapies that might be able to help with prevention of progression. But we'll see how that goes. I mean, it's very hard to find low-risk therapies, and certainly in terms of myelofibrosis, things are moving at an unparalleled pace with lots of exciting new advancements and options for patients in the future.
And Dr. Mascarenas?
To me, and I tell fellows all the time, I think MPNs are probably the most exciting hematologic malignancy, perhaps of all malignancies, because the science really informs the clinical development of therapies, probably more so than anything. And Moshe knows better than anyone. The first targeted therapies really came from a myeloproliferative neoplasm. So to me, it's the melding between the scientific discovery and the translation to the clinic that's very exciting as a clinical investigator. But I'm hoping is going to change our patients' lives in the near future.
And finally, to the man who put up with me at the University of Michigan, Dr. Talpas.
Actually, we got along.
We did.
Well, considering the other things that influenced us.
That's a different discussion.
That's a different discussion. But, okay, as you know, I've been a spoiled person. I developed treatments in CML, and we have seen linear transition and improvement. It was elegant, nice, targeted therapy and all of that. And then I decided to move. I decided I need some punishment. So I moved to myelofibrosis. And it clearly is not a linear story. And clearly it's complex. So I said maybe we should set the goals. We cannot, at this point, we don't have tools to eliminate the malignant clone. We don't know what drives it. It's not a single driver. It's not a JAK2 only. We know it. It's much more complex than that. Maybe we should focus at this stage in things that we can affect, the interplay between the malignant clone and the stroma. Because as it turns out, if we change fibrosis in this disease, we change the outcome in about 3/4 of the patients. In reality, only about 1/4 to 1/3 of the patients will die of transition to leukemia over the years. Many of the patients will die because they have liver failure, because they have pulmonary hypertension, because they just are wasted. If we can affect those processes, we change the disease. So maybe perhaps we should focus on things that we can affect. Cytokine interplay, cell-to-cell interplay, before we go and say how to eliminate that clone.
Great. Well, this has been a great discussion. Thank you so much for joining us. On behalf of the panel, we hope you found this peer exchange discussion to be useful and informative.